This week on the BackTable podcast.
The entire dissection should be meticulous and bloodless. When you pick up a parathyroid, you never grab the gland itself. You always grab the fat cap if you're grabbing at all. If you can do it without grabbing, that's wonderful. And, you can see the blood supply oftentimes, and you really have to, as you alluded to, you have to be very careful because there's no point in leaving a dead parathyroid behind because you took out the tiny arterial supply.
Hey everybody, welcome to the BackTable ENT podcast. My name's Ashley Agan. I'm a general ENT, and today I'm joined by a special guest host, Dr. Dipan Desai. He's actually a former resident of ours here at UT Southwestern, and he's now the Head and Neck Endocrine Surgery Fellow at Johns Hopkins. Welcome to the show, Dr. Desai.
Thanks, Ashley. I really appreciate being on the podcast and getting to join you guys for this awesome conversation today.
Yeah, and today we're going to be talking about the surgical management of parathyroid disease. And with us, we have Dr. David Goldenberg. He's a professor and chair of the Department of Otolaryngology at Pennsylvania State University in Hershey, Pennsylvania. He's a head and neck surgical oncologist. He's returning to the show after his first appearance in episode 35, in which we discussed thyroid nodules. So if you haven't checked that one out, I recommend you go back and listen to that one as well. But welcome back to the show, Dr. Goldenberg.
Thank you very much for having me.
All right. So just kicking it off, we're talking about the management of parathyroid disease. So, just starting out, what are the symptoms that these patients are coming in with? What does your history taking look like? What kind of symptoms are you expecting to see?
Well, all of us in medical school were taught moans, bones, stones, and groans, where people came in with profound symptoms. And fortunately, we don't see that kind of symptoms anymore. Patients will come in, about 20 or 30% will come in with a history of kidney stones, but many of the patients have nonspecific symptoms such as fatigue, mental fog, bone or abdominal pain, and poor sleep habitus. And since primary hyperparathyroidism often occurs in perimenopausal women, oftentimes those symptoms are dismissed, and the patients find them very, very vexing. And the good news is that parathyroid surgery actually cures many of these symptoms, if not all of them, and very quickly indeed.
And are most of these patients, when they're making their way to you, have they already been diagnosed from, labs? Like, is somebody, their primary care, somebody has kind of picked it up and then they said, okay, we need to send you on to kind of be further evaluated?
In my practice, the vast majority are sent to me either by a primary care physician or an endocrinologist. So labs are actually the core of the diagnosis. To have a diagnosis of primary hyperparathyroidism, ideally, one will come in with an elevated serum calcium and elevated parathyroid hormone. And that's really that's the core. There are other labs which are helpful, such as 24-hour urine calcium, which precludes the diagnosis of FHH. And that's important. And another one is vitamin D is also important because people who are vitamin D deficient and have primary hyperparathyroidism typically are sicker, their numbers are higher, and it should be addressed prior to surgery.
Okay. And then just to stop you, FHH being familial hypocalcemia.
Hypercalcemia. Yeah. I'm sorry.
No, it's okay. Just so that for listeners who may not know. And so most people, you think like primary care is kind of doing like annual screening and maybe checking, a BMP and maybe a vitamin D. And then if the calcium is high, then reflexively getting a PTH level? Is that typically how it works? Or
unfortunately, oftentimes a patient will come in with a long history of hypercalcemia that was being, quote, watched, end quote. But if things are done correctly, then the patient has elevated calcium. And, there are other reasons for elevated calcium. So those absolutely have to be ruled out. As a matter of fact, some of them are very serious, such as malignancy. Malignancy and primary hyperparathyroidism together are about 90-95% of all hypercalcemia. So once more serious things are ruled out and once say certain drugs such as thiazides and lithium are ruled out as a cause, then parathyroid hormone is done and the patients are sent on for definitive care.
And Dr. Goldenberg, how do you approach a patient who's maybe borderline? They've maybe had an elevated calcium some time ago and their labs vary between the normal range and mildly elevated.
This is where some clinical decision-making comes in. Depends on their symptoms. It depends on their parathyroid hormone. There are certainly patients who come in thinking that they have hyperparathyroidism because they read on the internet the symptoms and, their calcium and their parathyroid hormone are both normal or within the normal range. And, that's a conversation that's sometimes difficult. But if a patient is, sometimes it's high, sometimes it's low, I may get them an imaging study to see if there is something there. There have been patients where I said, this has not declared itself quite yet. Let's get you another calcium in 6 months. It really does depend.
And obviously we've been focusing mostly on primary hyperparathyroidism so far, and we won't delve fully into for the interest of time, into secondary or tertiary hyperparathyroidism. But how do you approach those patients, and is there anything different in terms of your history or your physical exam?
Well, patients who have secondary or tertiary hyperparathyroidism are typically, they come to us from nephrology. They're very sick, typically. Their calcium does not always have to be elevated. Parathyroid hormone can be very elevated. And those patients are going to go in, secondary hyperparathyroidism, if possible, should be treated medically. It's only the patients who are refractory who come to surgery. And, those patients will obviously get a far more extensive dissection and exploration.
And for your standard primary hyperparathyroidism patient, what are your criteria for taking them to surgery?
Well, there's the old NIH criteria for parathyroidectomy if symptomatic, with serum calcium, life-threatening, et cetera, et cetera. And like I said at the beginning, the vast majority of patients who we see do have symptoms. They are just vague or non-specific, but they're there and they really do bother the patient. So if the patient, in my mind, if the patient has a localizing study and if they have blood work, which is indicative, then they're going to surgery. I do have very few patients who are actually symptom-free, and they obviously have an adenoma, and they too probably, I would take them to surgery as well.
And just to back up, so most patients who have primary hyperparathyroidism have a single parathyroid adenoma that is causing that?
The vast majority.
Okay.
The vast majority of patients have a single adenoma. And then there is about 15 to 25% who will have more than one abnormal gland. And there is such thing as a double adenoma. More often they will have 4-gland hyperplasia, in which case all 4 of the glands need to be addressed. And rarely, and I say incredibly rare, there's 1%, there's a parathyroid carcinoma.
Interesting. And with the 4-gland hyperplasia, so that with that, there's not an adenoma, there's just all 4 glands are just hyper-functioning? Is that the right way to think about it?
Yeah, that's exactly what it is. All 4 glands are hyper-functioning. And, they're tricking the body into thinking that it needs more calcium in the blood, and it, leaches it obviously from the bone. And it's not good. Patients will develop osteopenia and ultimately osteoporosis if they don't get it taken care of.
And so with 4-gland hyperplasia, do we know what the underlying issue is? Like, why does that happen? And does that also happen, around, is that perimenopausal as well? Is that patient demographic different?
Not really. It should be the same mechanism. It just affects all 4 glands. And it is obviously a lot less common, but, to my knowledge, it's the same demographic. It's not that men can't get this. It's just that more often it's a woman's disease, and those are the age group.
Gotcha.
And then how do you go about elucidating what type of disease they have, whether it's an adenoma or 4-gland disease, in terms of imaging studies or any other evaluation prior to surgery?
There are studies that say that actually and this is counterintuitive, that if people have multi-gland disease, that their parathyroid hormone is actually lower. But all of my patients will get at least one imaging modality if they've not had it done beforehand. And if I'm convinced that the patient has primary hyperparathyroidism and their localization imaging or images do not localize anything, then that's the assumption that we go on, that they have multi-gland disease.
And what are the imaging studies that you prefer?
So because of the way patients are referred to us from the outside and they come into a tertiary medical center, oftentimes the patient comes with something already done. Sometimes it's adequate and sometimes it's not. If I'm the person working the patient up, I go with a 4-dimensional CAT scan. And, I've been doing this for a while and this has evolved over time. At first I did ultrasounds in the office, and then I was doing SPECT CT scans. And now, I believe that the 4-dimensional CAT scan is the most accurate for my practice. I don't typically do double scans as a proof of the disease. There are those who do, if they say that if you have 2 concurrent modalities that show this, then, you have your diagnosis. I personally don't do this. I go with the imaging in the lab.
And can you elaborate on what a 4D CT scan is?
So a 4D CT scan is a lot less cool than it sounds. When I first heard of it, I thought it would be spinning and holograms. There's none of that. It's basically a thinly sliced CAT scan with multiple phases of arterial and venous contrast and some nifty software which allow you to differentiate between parathyroid adenomas, lymph nodes, the thyroid gland. It also gives you some really nifty imaging of the arterial blood supply to the parathyroids, and that also helps find adenomas. I mean, we have to remember that the size of a normal parathyroid is the size of a grain of rice, and there is no imaging modality to date that can see a normal parathyroid. That being said, a parathyroid adenoma can be maybe the size of a raisin. They can be bigger too, but oftentimes they're not all that impressive when you get them out. I mean, it's nice to wear loupes because they look real big to you when you're taking them out, but they really are not that big.
And can you talk a little bit about the pros and cons of the alternative imaging modalities, either in-office ultrasound or sestamibi or SPECT CT scans?
Sure. So ultrasound is wonderful. It also, as long as the adenoma is at the threshold or above the threshold of detection size-wise, then it's great. You see a hypoechoic nodule. If it's inferior parathyroid, typically you'll see it. It's extrathyroidal, it's hypoechoic. Upper parathyroid adenomas are easier to see. You see again, extrathyroidal hypoechoic, and then you see thyroid tissue above it on the longitudinal scan. Great. Problem is, the 2 enemies of ultrasound are air and bone. So if it's below the clavicles, if it's in an elderly person, if it's below the manubrium, if it's behind the airway, you're not going to see it. A SPECT scan, SPECT scan is, injection of technetium and has a different washout time. Nowadays, most people are doing a SPECT CT scan fused, where you have functional anatomic data at the same time, superimposed one upon the other. And, the technetium stays behind in the adenoma when it washes out of the thyroid gland. And the CAT scan shows you anatomically where it is. And you put them together and you get a nice little area in either orange or blue that's illuminated, very nice looking. It will not see very small adenomas. And it also is a little weaker in flat adenomas. This is anecdotal. This is what I've seen when I was doing it. If the adenoma is flattened against the back of the thyroid gland, sometimes it won't be seen. And like I said, the 4-dimensional, CAT scan has been great. I'm not above, if someone comes in with a scan and it's non-localizing, I certainly will get them another scan in our institution. And it's important, if you're doing this kind of surgery, that you feel comfortable reading these scans yourself. And I do. I mean, I do get radiology's input, but, there are quite a few times where they've said there's nothing there, and I thought there was. And in the end, surgery, proves whether you're right or wrong.
Yeah. And so I imagine that the straightforward cases, come in, they have hypercalcemia, they have hyperparathyroidism, they have a scan that it has a localizing lesion where you're like, there it is right there. And so then you talk to the patient about surgery. But what about the patients who are not as clear cut? What if if the scan is not showing anything, but your labs are really suggesting that there is something? How do you approach that?
That's a great question. If I'm convinced and the patient is on board with having surgery, I will explain to them what the issue is, and it didn't localize, but I am convinced that there is a problem here and it can be fixed surgically. We can, then typically we'll do an exploration and evaluate all 4 parathyroids and decide which one or ones are the offending parathyroids in that person's case.
If the first scan doesn't show anything, do you routinely get do you at least get 2 scans that are not showing anything before you go to surgery, or will you ever have 1 scan and then talk about it and do 4-gland exploration just based on that? Like, let's say it's like a 4D CT, it's the best that you can do.
So if a person comes in, if they don't have a 4D scan and nothing is localized, they're getting a 4D scan in our institution before we move forward. If the patient comes in with, they've tried everything and it's been done someplace and I read the scans and the radiologist read the scans and we're convinced there is nothing, I typically won't get them a third, if they have a SPECT CT and a 4D CT, I'm not going to get them an ultrasound. They'll probably go straight to surgery. It really depends on how comfortable I am with the preoperative localization imaging. It's not, we will go over those scans even from the outside, and sometimes I don't agree, and I say, what? It's not convincing, but I think there's something on a left lower one, and that's the way I'll start it. And the patient has to be aware that this may end with a 4-gland exploration.
And once you've decided to take the patient to the operating room, can you talk a little bit about sort of what are your cutoffs for considering the surgery a success, and if you use intra-op parathyroid hormone testing to help guide you?
So if, the parathyroid is kind of like a chip shot and it's big and you know where it is and you take it out, that's great. But I routinely use intraoperative rapid PTH. And, conventional wisdom is you have a drop in 50%, then it's considered successful. That's supposedly at 10 minutes. I typically wait 15 just because sometimes there's some manipulation of the gland, and I just want to make sure that the drop is a drop. There are cases where the patient comes in with parathyroid hormone, which is not all that high, and it's even borderline high, and 50% would take it very, very low. That's where clinical judgment comes in. If I'm sure that I got the offending parathyroid or parathyroids and the hormone has dropped, but it's not exactly 50%, there have been times where I've said, okay, that's it. We got what we needed to do.
Can you talk a little bit about the actual surgical approach and technique?
Sure. So if this is a first-time parathyroid and we know where it is, I approach this much like I do a thyroidectomy. We make a very small incision about the level of a Coker incision, so 2 finger breadths above the clavicles in the midline. It's about an inch, a little more, 1.5 inches. We move the strap muscles aside, medialize the thyroid gland. If I know where it is and it's lower parathyroid, then sometimes you don't have to take the middle thyroid vein, but oftentimes you do to adequately mobilize the thyroid gland. And then we find the parathyroid, and if I'm doing a focused parathyroidectomy, then we just remove it and wait and measure the parathyroid hormone. If it's an upper parathyroid, it's very important to remember that the upper parathyroid is in close proximity to the recurrent laryngeal nerve, and you got to be careful. Sometimes it's not uncommon to have it right adjacent to the nerve. If I'm doing a 4-gland exploration, it's a little bit different. There, conventional wisdom says that you find all 4 parathyroids before you touch any of them. And the reason you do that is, you're saying, oh, I'm sure it's this one. And then you find one on the other side that's even bigger. And then you find yourself, leaving the OR with, the patient missing 2 unnecessarily. I typically do not use frozen section as a test for the parathyroid itself, but there are times where, a patient has a grape-like multinodular goiter with these little nodules falling off adjacent to, and you don't know if you have a little piece of parathyroid or a little piece of thyroid gland. In those cases, frozen section is helpful. If I do, in my practice, if I do a focused parathyroidectomy, the patient's closed up and they go home the same day. If I do an exploration, I treat it like a thyroidectomy and I keep those patients for 23 hours.
So you're identifying the recurrent laryngeal nerve when you are addressing like a superior parathyroid adenoma. And then if it's inferior, you don't necessarily need to go look for it.
You don't necessarily. I typically do. I think it's really healthy for the residents to feel comfortable doing that. So we do find it every time. I don't know. I don't really know. I mean, it is the gold standard during thyroid surgery. I don't know that I've read it for parathyroid surgery. We typically find it. My point was that the upper parathyroid is there. That's
Gotcha.
right where the nerve crosses, or the nerve is just comes to. But lower parathyroid, you can do a lower parathyroidectomy and not encounter the nerve at all because it's variable.
And are you using nerve monitoring for all of these cases?
Every time. Every case, every time.
Yeah, it makes sense. And any pearls as far as, identifying parathyroid glands without damaging their blood supply, especially with the normal ones being so tiny.
Yeah, that is a great point. And I'm sure Dipan will concur that loops are helpful. That they get their blood supply from the inferior thyroid artery, typically, both of them, not always, but typically. And, it's gentle handling of tissue. These are tiny little glands. Blunt dissection is done gently. One of the points that people have been taught for as long as they've been doing parathyroid surgery is the fact that you want to keep this bloodless because blood stains the parathyroids. The parathyroids have a different color than any of the surrounding fat if you look at it closely. They say it's ochre. It's more brown than fat. And it's really important to be able to see these nuances. So the entire dissection should be meticulous and bloodless. When you pick up a parathyroid, you never grab the gland itself. You always grab the fat cap if you're grabbing at all. If you can do it without grabbing, that's wonderful. And, you can see the blood supply oftentimes. And you really have to, as you alluded to, you have to be very careful because there's no point in leaving a dead parathyroid behind because you took out the tiny arterial supply.
Yeah, it's funny you mentioned that. I feel like I've heard a lot of different descriptions for the color of a parathyroid, but almost always food related, either salmon colored or nutmeg, and I find that of variable use, but super subtle sometimes. And then once you've identified potentially your offending glands, or if you're doing a 4-gland hyperplasia case, all 4 glands, can you talk us through your decision making on how much to remove and which glands you remove and what you choose to leave behind?
Well, I sometimes it's really hard to tell. I have taken biopsies of each gland and asked if they were hypercellular. I've looked at them closely. There are those who say to leave the lower one because the blood supply is more robust. If you're going to leave a lower one. You have to look at all 4 of them and evaluate which ones look the most abnormal, and you start with that. So if both lower ones are frankly abnormal, they're the first ones to go. If I can save a lower one because the upper ones are abnormal or more abnormal looking, then I will do that. It really is nuanced. I wish I had some real guidance. There needs to be a little bit of clinical decision making.
And if you are treating a 4-gland hyperplasia or a secondary parathyroidism case, are you taking typically 3 or 3.5, or is that not always a fixed rule?
Yeah, between 3 and 3.5, and I do follow the parathyroid hormone. There have been times that I've left 3 and it's done our job, and there have been times where, even that doesn't do it.
I see. And those labs are, can you talk through when you draw those labs? You said, I know, up to 15 minutes out, but what are the time points?
I draw labs 15 minutes after removal of whatever I'm looking after. I've used 10. I've had cases earlier in my career where 10 minutes just didn't cut it. And so I just kind of decided on 15. There are people who do 20 as well. I don't know about, how it is at Hopkins now with rapid PTH. In my institution, it isn't as rapid as its name. So there's a lot of waiting around, singing campfire songs while we wait for the parathyroid hormone to come back.
Yeah, it's the longest 45 minutes of the day sometimes. And so you're drawing just at 15 minutes, or you're getting one at 0, 5, 10, and 15 minutes?
No, I'm sorry. I should have been, So the anesthesiologist draws at the beginning of surgery. That's their baseline. And then at 15 minutes afterwards.
I see.
And I have them draw, when surgery starts, they take it from the foot. The patients wake up and ask why they have a needle hole in their foot. And, and that's where we do it. And at 15 minutes after excision of whatever it is I'm excising.
Okay. And obviously sometimes these cases can be tricky where you go in thinking you have a single localized adenoma, or you start doing your 4-gland exploration and one of the parathyroids didn't read, your wonderful textbook and is hiding. Can you talk us through sort of some of the steps and places you go looking for a parathyroid that's not where it's supposed to be?
Sure. Someone once told me, if it was easy, it wouldn't be fun. And, as you well know, Dipan, parathyroid surgery can be incredibly quick and easy and simple. And then there are times that it can be very, very frustrating because where is it? And it is paramount that the parathyroid surgeon understands the embryology of the parathyroid glands, because that's the key to where is that missing gland if something is missing. And I think that's what you're asking, correct?
Mm-hmm.
So, the lower parathyroids who have a longer descent, and therefore they are more apt to get lost. That's just the way it is in medicine or in anatomy, embryology. And, the most common place for a lost lower parathyroid is in the mediastinum together with the thymus. And other places that they can be would be, in the carotid sheath and even inside the thyroid gland. The upper parathyroid, and I have seen those get lost, they also can be in the carotid sheath. They're usually retropharyngeal or retroesophageal. I'm not talking about case reports where they're in the submandibular gland or some, really, really strange place. And, depending which parathyroid is missing, if you're looking for them, then, every patient should be consented for even if it's a focused parathyroidectomy, every patient is consented for a parathyroid exploration and possible hemithyroidectomy, which is the last place you look if you're missing a gland and you've looked in the mediastinum, you've dissected the mediastinum, you looked in the carotid sheath, and you're still missing a gland, then, we've all seen intrathyroidal parathyroid glands. Most of the intrathyroidal parathyroid glands are kind of in the capsule. They're not really deep in the substance, and sometimes you can actually see it. But, sometimes it's actually in the substance of the gland.
How common is that for it to be in the gland?
It's not common. More often, you'll see it inside the capsule, but outside the gland. Like inside the thyroid capsule, but not really in the substance. But that also is not all that common. Yeah.
So if you're not finding it, you should not be too quick to say, oh, it's probably in the thyroid.
No, you have to, if it's a lower, you really do need to dissect the upper mediastinum like you would a central compartment lymph node dissection. And you kind of pull up the thymus like, a magician pulling scarves out of a hat. And that's the most common place that you would find it. I have seen them in the sheath, and I've seen uppers behind the esophagus as well. So, it happens. The more you do, the more often you're going to see these things. And I guess those are the ones that take a little bit more clinical acumen.
And when you're dissecting out either the central neck compartment or looking in your thyroid gland, are you relying on your pathologist, or is it still sort of visual examination? And
I will absolutely rely on my pathologist at that point in time. That's a perfect example of when you need the help of the pathologist. Now, Dipan, I'm sure you know this because you do this all the time. When you see a parathyroid adenoma, there it is. It looks like a little piece of liver. It has a certain look to it. Here we go again with food, right? But sometimes it's hard to tell. For example, Hashimoto's thyroiditis is incredibly common. Hashimoto's thyroiditis comes with a lot of these little round lymph nodes. And sometimes it can be confusing. It's not out of the realm of possibility that your patient has Hashimoto's thyroiditis and they have hyperparathyroidism. And then sometimes you are looking at a whole bunch of little grapes and you have to make sure so that this is in fact, the parathyroid, and you just didn't remove an inflamed lymph node. And so, yes, we definitely would rely on the pathologist if I'm not sure, or if I want to differentiate thyroid from parathyroid. Absolutely.
And obviously the worst case scenario is, as you mentioned, super rare, but a parathyroid carcinoma. And I know that diagnosis can be very difficult. Have you ever encountered that? And what are sort of some of the signs intraoperatively that you might be dealing with something that's not a normal parathyroid adenoma?
Well, before we go intraoperatively, preoperatively, patients who have parathyroid carcinoma are more apt to come with incredibly abnormal calcium and parathyroid hormone. So their calcium can be dangerously high, and that's the first thing that can bring them to medical attention. They've been in the emergency room, they've gotten their fluids, and no one knows why. Oftentimes, parathyroid hormone will be incredibly high. So if primary hyperparathyroidism, you'll have parathyroid hormone in the hundreds. Parathyroid carcinoma, you could have it in the thousands. They will often come with a mass in the neck, while a patient with primary hyperparathyroidism, their physical exam is completely unremarkable unless you want to count aches and pains and, kidney stones. So they may have a lump in the neck, a mass in the neck, a fixed thyroid, something that doesn't seem right. And those patients should be treated like any other patient with an aggressive cancer, more like a squam than with thyroid cancer in my mind, because parathyroid carcinoma, as rare as it is, can be pretty nasty. So those patients will probably lose at least half the thyroid, perhaps a neck dissection, depending on what is found on preoperative imaging and what you find intraoperatively. Obviously, like any other oncological case, anything it is stuck to needs to go. So fortunately, a rare entity.
And those patients probably get a preoperative FNA since they have, a mass that's big enough to biopsy, or no?
They do, or they can. I've only seen this in a handful of cases in my career, and that's how uncommon it really is. And most of the patients, trying to think back because it really is not that common. I guess some of them were originally thought to have thyroid cancer because that's what it looked like on the imaging. But an FNA, if directed correctly with washouts, could probably do the diagnosis for you.
And then once you've completed your surgery and you've successfully found the parathyroids and your labs have corrected, postoperatively, you mentioned your sort of admitting versus discharge patterns, but do you give them any sort of medication afterwards or any calcium taper, anything special you do in the postoperative period?
We do typically give them a small calcium taper. Patients, depending on, and I guess I wish I could tell you that I've been successful in being able to differentiate those who are going to develop hungry bone syndrome or something like that. It happens. We just don't want the patients to go home and start to feel sick. So they are given calcium taper. I forgot to mention, I think where I have mentioned at the beginning, hopefully their vitamin D was optimized before surgery. We try and do that. But yeah, they go home, they're usually happy, and we DC their calcium pretty soon afterwards. And most of them are just great. They're very happy. They feel great. It's a very gratifying surgery, to be perfect, as a surgeon, to be perfectly honest, because their symptoms abate very quickly. As a matter of fact, we published a study in Laryngoscope, I believe in 18 or 19, where we looked at cognitive symptoms, depression score before and after surgery. And we found that within a week of surgery, the patients were like new people. Their scores came up, their depression was down. And right now we're actually doing a study looking at using actigraphs to look at patients' sleep habitus before and after surgery, because most of these patients do very, very well and they feel like new people very soon after surgery.
Well,
yeah, I agree with you completely. It's a super gratifying surgery. And oftentimes, just as you mentioned earlier in the podcast, they've sort of had symptoms that have been, either misdiagnosed or neglected as just part of aging for a long time. And to do something where they pretty much instantly feel better is pretty awesome.
If I could give a title to parathyroid surgery, the title would be, quote, "You've given me my old wife back," end quote, because I've heard so many husbands say that after parathyroid surgery.
Well,
And you briefly mentioned hungry bone syndrome. Can you talk a little bit about what that is and who is prone to getting it?
Sometimes what happens is the serum calcium decreases relatively quickly because of recalcification of the bones. Remember, the bones were, the bones got leached of their calcium, and now they want it back. It's called hungry bone syndrome. And it typically happens within the first days or weeks after surgery. And it's typically a sequela of more symptomatic hypercalcemia. And people feel yucky. They have muscle cramps, and they have a clinical picture, of tetany, just like they would for any other hypocalcemia. And that's one of the reasons that we support patients with calcium orally. If this happens, then they come in and they usually get intravenous calcium infusions. I mean, it can be relatively dangerous if it's not treated at all, because it is a form of hypocalcemia. But it's not common, but it's something that we do see, and the patients typically need to be made aware of the signs of hypocalcemia so that they could recognize it once they go home. That's why it's important to educate your patients. In my practice, we're the only academic show in town, so patients come from far and wide across the Commonwealth of Pennsylvania, and certainly you don't want someone who lives 4 hours away. They have these signs and symptoms, and they don't really know what's going on.
and so post-operatively, are you checking calcium levels routinely?
I think they get a calcium check before discharge typically, and they go home on calcium. I wish I could tell you exactly what the protocol is. I don't know.
Do you just use like Tums, like calcium carbonate?
Yes, typically we do. Yes, calcium carbonate.
Cool.
And obviously a lot has been made in regards to innovations around parathyroid surgery with autofluorescence of parathyroid glands during thyroid surgery. Can you speak to if that's useful at all during parathyroid surgery or trying to find a hard parathyroid gland?
Well, I can't speak from experience because I don't know. I don't use it. In theory, the autofluorescence of parathyroids that they fluoresce has been used so you don't accidentally avulse. You can see them so you don't avulse them during thyroid surgery. And, people have said, okay, can we use that same technology to find a hard to find parathyroid? Again, haven't used it, but I've been around long enough to know or to remember when they did the same thing with methylene blue. There have been multiple attempts to try and dye the parathyroid in order to find it. I guess anything that helps is wonderful. Typically, the surgical principles are enough to find the offending parathyroid in my mind. But again, I've not done it, so I can't speak to it.
No, sure. Thanks for letting me know.
So rounding out this conversation, what I definitely want to do is give Dr. Goldenberg the opportunity to spotlight his book, Head and Neck Endocrine Surgery, so that we can kind of let our listeners know about that other, that resource to check out. Can you tell our listeners a little bit about that?
So I published a book in, I believe, 21 called Head and Neck Endocrine Surgery, a comprehensive textbook, surgical and video atlas. I have contributors who are the who's who of thyroid and parathyroid surgery, including your mentors there at Hopkins, both, Dr. Russell and Dr. Tufano, who's now in Sarasota, as well as other people whose names, those of us who do this, that know their names. And it covers all aspects of medical and surgical management of both thyroid and parathyroid disease. And when I wrote this book, first of all, I included, novel or so-called novel topics such as radiofrequency ablation, risk stratification, remote access surgical techniques, molecular testing, all the things that those of us who are doing this now use routinely, but may not be familiar to those who don't do it as often. And it has 5 sections on thyroid gland, basic science, historical, ethical, medical, legal concerns, all those things. And then 2 sections on parathyroid disease and parathyroid surgery. And what makes it unique is that it's kind of written for the modern learner or for the millennial. It has a lot of illustrations. Each chapter comes with a high-yield case report to kind of underscore what the issue is. It has key points and pearls in every chapter called Points to Ponder, where the reader is asked a question to try and underscore that they understood what they just read. It has annotated bibliographies whereby references to the most, the landmark studies are written out with a little abstract. And of course, there's, 30 or so videos for surgery. It was published by THIEME, THIEME, which is a medical publishing house out of Stuttgart, Germany. Yeah.
So listeners could probably find it on Amazon?
Oh, yeah.
Oh, yeah? Yeah.
You can do it on Amazon and,
yeah.
Absolutely. Amazon.
Usually
and
a pretty good resource. Wherever you find your medical textbooks, probably.
Correct. Thank you very much.
Your medical textbook store of choice.
You're right.
Awesome. Well, thanks so much for taking the time today. That was definitely a great review for me, as I haven't, been doing these over the last several years. And Dipan, thank you so much for joining. It was great kind of having your point of view and being able to reconnect with you. So thanks for coming on the show today.
Thank you both. And please give my best regards to my friends at Hopkins.
Definitely will do. Thanks, Dr. Goldenberg.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson,
Josh McWhirter,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Thanks again for listening, and see you next week.